All right. It is a little bit past 1 Eastern time, and so we're going to get started here. First, I want to welcome all of you here who are either attending this webinar live or hearing the recorded version of this webinar on the Collaborative Family Healthcare Association's video stream on integratedcarenews.com. Thank you for joining us. We've got a really great topic, a salient topic for healthcare today and primary care specifically. We are excited to have our presenters today who have put a lot of time and effort into researching, studying, and clinically testing this whole issue of unexplained symptoms and the incidence of traumatic events in patient lives. So it's a great topic today. Before we get started, let me first let you know who I am. I'm Dr. Naftali Serrano. I'm the director of the Collaborative Family Healthcare Association. If you're joining us, it's because you probably know that we are an association that promotes the integration of behavioral health and medicine. And so that's a really big world of topics and items related to making healthcare and healthcare teams serve our patients in a holistic fashion. So this is a small slice of that you're going to get today. If you are interested in that world, you should know that we have our annual conference coming up in Denver, Colorado this October 17th through the 19th. In fact, the presentation that you are either seeing live or seeing in recorded fashion today is going to be, a version of this presentation is going to be given at the conference. So if you like what you hear today, you're going to love what you hear at our conference. So for more information, go to our conference site, integratedcareconference.com. To view this again, you can view it or share this video with others at integratedcarenews.com. The only other housekeeping feature here is we want this to be an interactive event. So you can easily use the chat feature. If you kind of move your cursor around, you'll see the chat feature there at the bottom of your screen. I'll be monitoring that chat feature and then feeding questions to the presenters today. So as we go, please put your thoughts, reactions, and I will share those with the presenters who will either respond to questions or respond to your comments. So without further ado, I'm going to turn it over to our presenters today. Thank you all as presenters for taking the time out of your day to prepare this and to educate our listeners on this. So looking forward to the conversation for the next hour or so.
Thank you.
Thank you, Naftali. All right, hello and welcome to the presentation entitled Quandary of Unexplained Symptoms, ACEs Screening and Intervention in Primary Care. My name is Tyler Lawrence. I'm the residency behaviorist at the CMAR Marysville Family Medicine Residency. We're based in Marysville, Washington, so just about 45 minutes north of Seattle. And we also have Dr. Dave Clark, president of the Psychophysiologic Disorders Association. He's coming from Denver today, but he's typically in Portland, Oregon. And he spent most of his career as a GI physician. And then we have Dr. Susan Wiley, vice chairman of the Department of Psychiatry, the Lehigh Valley Health Network in Harleysville, Pennsylvania. And she's been a psychiatrist for most of her career.
Thanks.
Welcome. All right, so we do have a faculty disclosure, as you can see here. All right, learning objectives. So it is our hope by the end of this webinar that you'll be able to describe medical and mental health outcomes associated with ACEs, identify methods used to assess for ACEs, and we specifically want to get into, we'll do a critique of a few different types of methods for screening for ACEs. So we think that'll be nice for you. And lastly, we hope that you'll be able to identify 3 evidence-based interventions used to address trauma. We'll get into more than 3, but our hope is at least 3 will stick with you. Okay, so ACEs and PPDs. What are adverse childhood experiences? What are psychophysiologic disorders? why should you care, and why are they being presented together? I'm hoping in the next few slides I can answer a few of these questions. All right, so in terms of adverse childhood experiences, or ACEs, what is it and why should you care? ACEs have been defined as stressful or traumatic events which occurred in childhood, such as abuse or neglect. Examples could include sexual abuse, not having food provided by the parent, physical abuse, even a few others, of course. And ACEs are pretty common. So I specifically picked a study that looked at the prevalence of ACEs in primary care adults, since my guess is most of us work or have worked in primary care. And the prevalence for those with 0 ACEs is a fair proportion, so 42% at least cited in this study. But those with 4 or more ACEs in this study was 18%. And the reason that 4 or more ACEs was used as a cutoff in this study is both in this study and other studies, 4 or more is often the number used to describe like a severe or a serious amount of ACEs happening to a person. Okay, so so this is a fairly prevalent thing, and it's also something that can be detrimental to a person. ACEs have been associated with quite a number of negative health consequences. These include cardiovascular disease, chronic lung disease, headaches, autoimmune disease, early death, and even mental health and addiction problems, including depression, PTSD, and substance use problems. So again, most of us are probably physicians, primary care physicians, and behavioral health. These are all problems that we want to do something about. And what is a psychophysiologic disorder? So a psychophysiologic disorder has been defined as physical symptoms. They're not caused by organ disease or structural abnormalities, and that are linked to psychosocial stresses. So what do you think about this is, for example, maybe a person has severe itching that bothers them quite often, but there's no identifiable physical cause for that itching. However, this is an example taken from Dave. Whenever a person only has this symptom when driving to work, which they don't enjoy their work one bit. So there seems to be a stress link to those symptoms. And again, I chose another study that looked at primary care prevalence rates. And in fact, this is an international study taken from, 32 different studies from 24 countries. So I try to be pretty comprehensive about this. In this study, 40 to 49% of patients experienced at least one medically unexplained symptom. And at least between 26 to 34 had at least one psychophysiologic disorder. Examples in this study included fibromyalgia, chronic fatigue syndrome, just to name a few. So again, as you can see, such psychophysiologic disorders and medically unexplained symptoms quite common. And as you can guess, there are associated challenges with PPDs, psychophysiologic disorders. These include high rates of healthcare utilization. Of course, if I'm itchy and it's very distressing to me, I want to know why. And a lot of the tests that might usually be able to detect why severe itching or a rash occurs might not be useful for this type of problem. So patients might keep coming back looking for a particular type of answer, an answer that a medical test can give, and it might not occur for this problem. This can lead to strained physician-patient relationships, but also can lead to suffering not knowing why a person is having to deal with one or more symptoms. Okay, so next part, I hope to convince you about why these two are being presented together. So I'm going to look at two studies. First, I'm going to look at a study taken from the general population in Wichita, Kansas, and looked at the odds of having an ACE, comparing those with chronic fatigue and those without chronic fatigue. And they found a childhood history of physical abuse had about a moderate association with having chronic fatigue as an adult. And as you can see, the strongest relationship is having experienced sexual abuse as a child, but there is a large correlation with having chronic fatigue as an adult. Of course, this study actually covered more ACEs than just physical abuse, sexual, emotional, and physical, as you can see listed here. But in general, having any type of ACE, there's a moderate association with having chronic fatigue as an adult. And this study's a little different. I'll compare some of these differences in just a little bit. But they looked at childhood events associated with somatic symptoms in a sample of primary care adult women in Mississippi. So again, you have a different setting, different population, and even kind of measuring something that's a little different. However, this study still found those who would experience various types of ACEs were more likely to have somatic symptoms as an adult. What's interesting just to note is in this study, those who had experienced emotional abuse, that had the strongest relationship with experiencing somatic symptoms as an adult. The prior study, which I'll go back to, found having experienced sexual abuse as a child had the strongest relationship with having chronic fatigue as an adult. So again, we discussed this. We do think that just different setting, different population, they were measuring something a little different might explain some of the prevalence or the correlation differences between these two studies. However, it's really nice. This is a really nice visual for seeing how ACEs and, for example, somatic symptoms are related. All right, so what can we do? Hopefully we know what the problem is. We feel it's important. We suggest that we can screen and intervene. So again, I'll cover three different types of screening tools to identify ACEs. They're commonly used, and to introduce a new one, or actually I'll Dave introduce a new one. I'll explain who do we screen and kind of give how we can do it. And both Dave and Susan go over interventions that can be used by providers, either behavioral health or other medical providers for identified patients. We go over interventions that can be some that are brief and some that might be more time intensive. So we just hope to give you tools for whatever your profession allows. Hopefully you can borrow the right tool for the right circumstance. All right. When it comes to screening for ACEs, we do think everyone should be screened. And the reason is like ACEs obviously affect a lot of our patients. And not only that, Fleddy, who is who came up with the original ACEs study, he found that a conversation about a positive screen reduces office visits by 35%. And he even made a note in the study that patients most oftentimes felt very comfortable talking about ACEs with the provider, meaning that they didn't just scare patients off. They felt that there's something clinically relevant going on, like some clinical therapeutic value. When should this occur? At the beginning of treatment, so intake is preferable, but it's not always necessary and perhaps not always feasible given circumstances. And how often? So since our childhood history pretty much remains the same, we always feel like ACEs need to be screened for just once. But as new symptoms might arise, consider doing a stress inventory, which Dave will get to later. So about the actual screening tools, there are a few options out there. There's the 17 item, the 11 item, 2 item questionnaire, which really nice how brief it is, and then the 1 question that Dave will describe. Now we do feel like with the first 3, there are pros and cons to all of them. So one thing that's nice is, of course, using the, for example, the 1711 item. There's been studies that have shown that 4 or more ACEs correlate with many chronic medical conditions and early death, as I described earlier. It's nice that it has some research to it. However, I think a lot of folks, we feel, and also discussing it with others, feel that these items can be too long to use in office, but potentially could be used for self-administration and the waiting room, perhaps in an intake packet they might get. The 11 item admits emotional abuse and physical neglect, which we feel are important ACEs. Also feel that both the 17 and the 11 item admit some pretty important adverse childhood experiences. This includes experiencing poverty, being bullied at school, which is quite common, observing sibling or father abuse, community violence, or race abuse, and the list goes on. So it's nice because it's longer, but still not. This still leaves out some important traumatic experiences. And the 2 item tool is nice, of course, because it's quite brief, but it's not necessarily sufficiently sensitive or specific enough to perhaps be useful. It's nice because it's brief, but the utility might be questionable. And with the 2, 11, and 17 item, it measures the number of positive categories for ACEs. But however, we suggest, and we feel this is pretty intuitive, that the severity, duration, absence of resources, or severity and duration of the ACEs, the absence of resources, is significant and maybe more significant determinant of medically unexplained symptoms than experiencing just a category or various categories of trauma. However, this does require more study. However, at this point, I'll transition it to Dave so you can talk about the 1 screen questionnaire.
Okay, thanks, Tyler. This is the single item that I've used and found helpful over the last 20 years, and it's helpful for a couple of reasons. Before I get into describing it in more detail, I just wanted to briefly mention a couple of resources that people might be interested in who want to learn more about the diagnosis and treatment of psychophysiologic disorders. And the first is that our special interest group did a webinar in the winter of 2017 that's in the archives on the cfha.net website. So that goes into the diagnostic process in more detail. And the second is that there's a webinar, a video-based training course that's going to be released by the PPD Association in the summer of 2019. That's about 2.5 hours long, has 14 different modules to it, a lot of graphics and some patient role-playing simulations that will go into even more detail on how to diagnose and treat this population. But this question I like for a couple of reasons. It's just read it. How would you feel if you learned that a child you care about was growing up exactly as you did? It's a good question for a questionnaire that the patient can fill out in the waiting room. It also can be used in the exam room. In the exam room, I don't usually ask it as my initial question about childhood abuse. I'll usually ask a more general, a less sort of direct question, such as, were you under stress as a child? Can you tell me a little bit more about what went on? And you'll find when you're asking those questions that patients have a very strong tendency to minimize what they went through. After all, they don't have a parallel life to compare it with, so their experience is frequently all they know, so they tend not to see things as being as bad as an objective observer might. They also, in many cases, had experiences that in order to cope with them, they needed to suppress their emotional reaction to what was going on. So as adults, when they're in your office with unexplained symptoms and they're looking back at their childhood experience, they often simply don't recall things as being as bad as they really were. However, when they imagine their own child or some other child that they know that they care about trying to cope with those same experiences, and I'll sometimes ask them to do a thought experiment where they're imagining themselves as a butterfly on the wall of their childhood home while they watch a child that they care about try to cope with everything that they coped with, even for just a week or a month. And that frequently leads to a profound revelation for people as they imagine that child trying to cope. And it gives them a much more accurate sense of what it was they had to deal with, and also connects them with a lot of the suppressed emotions that they may have had at that time and that are still active in the form of causing their physical symptoms. I also was interested in whether this single question connected with the full ACE score. So I took patients' responses to this single question. I gave them 4 choices, whether when they looked back at a child growing up as they did, that would make them happy, whether they would feel neutral about that, whether they would feel sad or angry about that, or whether they would feel very sad or very angry. And you can see the 4 different responses along the x-axis of this bar graph, and on the y-axis is the patient's ACE score. And as you can see, the less happy they were thinking about a child trying to cope, the higher their ACE score. So there was a very good correlation. I've got data sets from both Oregon and Colorado that both came in at about 0.66 on the correlation coefficient here. So it's a good single question way to access the full ACE score. And the other major advantage that it has is it covers actually more experiences than even the full ACE questionnaire does. There are a number of holes in the full ACE questionnaire, such as bullying at school, witnessing violence toward a male parent, early medical trauma, family secrets, a number of different areas that can and should be considered ACEs and that can have the same outcome for the adult that are simply not asked about, even in the 10-item questionnaire. But this question kind of works as a summation of everything that the child went through. Okay, on to the next. So when you're evaluating a patient that may have a stress component to their physical symptoms, very often once you start asking questions about stress in their life at the moment or about their self-care skills, you find that some of these patients are going to want to tell you about their entire life story, and that they may want to spend the next 2 hours with you sharing this information. And obviously nobody is going to have the time resources for that. So at the same time, we want to honor their willingness to disclose. And a good way to do that is to simply ask them to make a list of all the stresses in their life, both past and present. And this is a good way to bring the conversation to a close in a timely fashion, but also to get the patient working on their own stress issues and just becoming more consciously aware of them by writing them down. And they can then go over the list in a more time-efficient manner when they come back for their follow-up visit. And not infrequently, the patient will be prompted by writing this list to find some solutions to some of the sources of stress. And if they've got a psychophysiologic symptom connected to those stresses, it may have improved by the time of their first follow-up visit, which helps you recognize that you're on the right track diagnostically, and frequently can help you curtail any kind of mega workup you might have done in the past on this population. Good. Next. For patients who have trouble with their self-care skills, which turns out to be a surprisingly common problem. People who take care of everybody else in their world but have difficulty putting themselves on the list of people they take care of. Not infrequently, they've grown up with ACEs that prevented them from getting adequate self-care and playtime as children, and consequently as adults, it's something of a foreign concept to take time for their own recreation, relaxation, personal joy, and they don't. They're kind of live lives that are on a treadmill that they never get off. When you ask them, what do you do for fun? They have trouble coming up with much. So those individuals, I usually recommend that they take, if they possibly can, an afternoon a week, get out of the house away from their usual responsibilities and just take some time to find activity that has no purpose but their own joy. And I warn them they're going to feel guilty at first because this is something new. But the more they practice it, the more they do some trial and error, the better they'll get at it. And once they have this skill of putting themselves on the list of those they care for, they'll have it for life. And anytime their stress level gets up to the point where it's causing physical symptoms, they'll now have a way to bring that back down. For people who grew up in a stressful environment, not infrequently, they've got significant buried, repressed, suppressed emotions. And the approach to that, many of them are obviously going to need psychotherapy, some of them for years, but even patients with fairly severe symptoms will often find that they're experiencing improvement early on in that process. A couple of things that can be done even in a primary care office are that same thought experiment of imagining a child you care about growing up exactly as you did. And that helps people to recognize that they've got one or more negative emotions that may have been suppressed for a long time. Very frequently anger at the treatment they experienced, but can also be fear, shame, grief, or guilt, depending on the circumstances. And once people have connected with some of those emotions through that thought experiment, then the next step is for verbal expression of one kind or another. It can be as simple as speaking into a recording device, or speaking to a therapist, or even better, writing it down. And I think the next slide shows some examples of, and there's good research behind it, some writing techniques for ACE survivors here. One is simply writing a letter to one or more ACE perpetrators, not to mail it, just to write it, to put your thoughts and feelings down. And oftentimes once people start writing, they write a lot more than they expected to. And not infrequently, it can have a really cathartic effect for people, and physical symptoms not infrequently respond just to this one exercise. And you can see some of the other examples there. There's an excellent book by James Pennebaker called Opening Up. It's, I think, now in its 3rd edition, that reviews a lot of the research in this field and some of the techniques that have been shown to be valuable in this population. Next. Okay, that's the end of my group. Thanks.
Thanks. Thank you, Tyler and Dave. So just a comment about what's been said so far, which is that, so there's this powerful data that tells us that patients are coming in with these medically unexplained symptoms that are very likely related to childhood experiences rather than physiologic pathology. And this really calls upon the primary care physician to think differently about the nature of what they're going to do and how they're going to care for this patient. And I want to just highlight that that identifying that there is a psychological underpinning and an experiential underpinning to these symptoms is now calls forth a different kind of interaction between the primary care physician and the patient, one that you may not feel all that prepared for or comfortable with, which is why we felt it was worth talking about some of these interventions and how they might manifest in the primary care setting. Another important point is we really want this dialogue to shift early on in the patient's presentation and not after the elaborate workup, that if you come to think about psychophysiologic disorders after you've done the workup, patients tend to come away with a feeling that you're communicating, well, it's only in their head, and that actually devalues their symptoms and their suffering. Certainly, whether it comes from pathology, organic pathology or psychopathology, the suffering is the same and worthy of your engagement around the relief of that suffering. So what we're hoping to create here are some interventions that you can use in the office, or if you're fortunate enough to have a behavioral health provider in your office, that you could engage your behavioral health provider to assist you, and that you do so early on in the evaluation of these disorders, that you think about the adverse child events as something that may be causative or contributing factors to these psychophysiologic disorders, and that you think about it early. So we're going to be going through some strategies that you might use, and I just want to highlight that we wouldn't expect you to do all of these things all at once, that this is, once you've identified a patient that's suffering from a psychophysiologic disorder, it shifts the dynamic from a medical workup to, but you still want to see these patients regularly and follow up with these interventions in a slow but progressive fashion. And so I'm hoping that you won't feel overwhelmed by these interventions, but that you feel invited to put your foot in the water and test them out and try them and have patients come back frequently and let you know how they're doing. So the first intervention is a behavioral activation therapy, which has been a treatment well studied to actually help patients bring on more positive behaviors and reduce negative behaviors. And this, for instance, Dave mentioned how much difficulty patients like this have in just doing things that are fun or for self-care. So that might be identified as a positive behavior, and you might want to increase the frequency of that behavior, of taking care of themselves, of going out for a walk, of exercising, calling a friend. And you might want to reduce the frequency of their, for instance, binge eating or eating the wrong things, or immobility, self-withdrawal, isolating themselves. So you might just identify one or two positive behaviors or one or two negative behaviors and talk about how you might increase those positive behaviors and reduce the frequency of those negative behaviors. And that's been shown to be of help with patients with traumatic disorders. Progressive muscle relaxation is a relatively easy strategy to teach. There's a simple kind of script that you could either print and offer to patients that it has been very well shown to reduce physical tension, and this was particularly shown to be of use in patients with somatoform disorders, but just an easy way to teach patients how to relax their muscles, which then has a relaxing effect on the mind. So very simple and easy to provide a script. Journaling is another intervention that we've mentioned, and inviting people to write, giving them something specific to write about. This is a whole topic in and of itself, but it has been shown to be of use with patients with trauma. And we can talk some more, a little bit more if there's some questions too, about how you might quickly and easily structure that journaling assignment and how you handle that in the office. In other words, this is not that they're going to bring it back for you to read. But be clear, this is for their reading only. Tyler, next slide, please. So mindfulness strategies have been very well documented as helpful in the management of anxiety when it comes from a variety of different sources. And anxiety is often present with these psychophysiologic disorders. Just a word about what mindfulness is, for those of you who may not be familiar with it. It is a training to bring your attention out of the usual habitual rumination, worry, for instance, or somatic preoccupation, as is often the case in this patient group, to bringing the attention to just what's present here in the present moment. So noticing what's present in the body just now, what's present in the mind, what's present in the heart, the feelings, without judgment, but with a kind of gentle curiosity, allowing things to be as they are, and just really noticing, bringing the quality of noticing with kind curiosity to what is unfolding in the present moment. So these mindfulness strategies are readily taught. You can easily bring a patient into the office and offer a few moments of mindful practice. It's often helpful when patients notice stress in their body, that they understand and recognize what that stress is manifest in their body, whether it's a pit in their stomach or a sensation of flushing or sweating or shortness of breath or palpitations, whatever immediate acute noticing they have of what happens when they're feeling stress, that mindfulness strategies can be readily used to induce a feeling of relaxation right here on the spot, even in the office, and you can have them easily practice at home. There are many applications that are available for their phones or on the web. Excuse me. And mindfulness training also invokes learning how to treat oneself with compassion, which is a very powerful therapeutic intervention for patients who have not been treated with much compassion in their early lives. So I'll talk some more about compassion and its role in the doctor's office in a minute. Could you just go back for one moment, Tyler? Thank you. So one of the most powerful parts of a mindfulness intervention, I would say, really rises out of the sense that no matter what symptoms you have, no matter what your physical complaints, no matter what you've been through, that there is more right with you than wrong with you, and that you have a lot of strengths. You have a lot going for you. And so touching into what those internal resources that are already present can be helpful. And that could be a writing exercise, so you're here with this symptom or these symptoms, but what's going well for you? What's right? And that will not be necessarily an easy exercise, but people have resources. They know how to work hard, for instance. They show up for work. They can be disciplined. They have a pet that they feel close to. They have a relationship that they feel supported by. So helping people to identify their strengths is another helpful strategy. And this gets us to helping patients to see themselves as a hero. And I really attribute this slide to Dave and some of the brilliant work that he does with his patients. And he helps them to shift from feeling of shame, which arises from being victimized as a child, to moving towards self-respect, seeing themselves as heroes in their own narrative. This is an extremely powerful intervention, and it can be done as you come to understand what some of these traumas are that patients have gone through. You help them to replace their blaming themselves, which is such a common element in victimization, is what did I do to bring this upon myself? Often this feeling of blame is cultivated by the perpetrator, but often it's just a natural arising that I must not have been loved, cared for, or protected because there's something wrong with me or I failed in some way. So reversing that self-blame and replacing it instead by compassion, for what it is that this person has endured, and how it is that every human deserves to be treated with tenderness and kindness. And that they switch from seeing themselves as a victim of something and replace this view of themselves with a sense of pride in their resiliency and their survivorship. After all, they've arrived in your office and they're looking for help, and that defines the interaction that you're having with them, and therefore you can emphasize these as strengths, like you're here, you've gotten through all this, and now we're on a path together of helping you to overcome the remnants of this trauma. And so one of the things that Dave does is that he actually hands his card over to the patient and write on it, "You're a hero." And what he's doing here is actually lending his authority. He's to the award. It has Dave's name on it, and you can use your own card and say, the patient may hold their physician in high esteem, and you're returning that esteem in a tangible way. It has a very powerful impact on patients, and they can take it with them, and they can display it on their mirror at home or on their rear view mirror in the car. So it's a tangible reminder, a constant reminder that they are a survivor, and that their heroism continues every day. So continuing in that realm, we can ask, and this again is work that would take place over time in subsequent visits. So you bring the patient back in a couple of weeks. How's it going? I have asked patients to imagine that a child, this is Dave's question, but I have patients actually imagine the child that they were, and have them offer that child that they continue to carry inside them the tenderness and support and reassurance that they may not have gotten during their childhood. I remind patients to actually practice by, before they get up in the morning, to bringing to mind the small child that was neglected or bullied or physically abused or sexually abused, and bring that child to mind, and really encourage that child, offer them that kind of tenderness and love and support that they, as an adult, they may be able to offer to their own children, but that they did not themselves get. And this can be a very powerful intervention as well. And so that's an assignment. Bring to mind that child that you were. Bring it to mind every day. Talk to her or him. Reassure them. Spend a few minutes every day reassuring that child, and come back in a few weeks and tell me, how is that going? How's that practice going for you? Dave talked about getting a stress inventory, and this is something that can be done at any stage in the treatment of a patient with a psychophysiologic disorder. Is let's take a stress inventory. What's going on now? What could be contributing to your symptoms at this time? Another thought is to take an inventory of resources. So perhaps you were missing resources as a child. You were alone. Maybe you had a sibling or a grandparent that was protective. Maybe you didn't. But let's take an inventory of your current resources. What is available to you now as an adult that might not have been available to you as a child, and to list them and to count on them. And again, recognizing that living with their disorder and living their life as an adult requires heroism every day to survive, and that they continue to reinforce that heroism as they move forward. So Dave talked a little bit about how difficult it is for some of these patients to take care of themselves. And I sometimes wonder where the patient is in the Maslow's hierarchy of needs. Tyler, could you just forward, please? So this is the inventory, and you can see that if patients don't have a steady or secure place to sleep, or if they have food insecurity or severe financial insecurity, it's difficult for them to really begin to address their other needs. That's not to say that we would ignore these other needs, but just to keep in mind that that one's needs for physiologic care and safety will precede one's ability to work on issues around friendship and intimacy and family connections and self-esteem and so forth. If you go back to the previous slide. So again, helping people to see where they are currently, what their resources are in that hierarchy, and what do you need now? What are the most present pressing needs that you have? And how will you take care of yourself? What does your body need? What does your heart need? What are the resources that you have to meet those needs now? And what maybe are future needs that we need to park and understand that you're on a path, on a journey towards healing, and that some of these things may come later. And helping people to realize they don't have to do it all at once can sometimes also be helpful. So self-care is a real challenge, as Dave mentioned, for these patients. And so you really want to help them set their intentions towards self-care and be very specific and immediate. Some people don't do any exercise, so asking them to get on an exercise bicycle is, may not be realistic. So let's keep the goals very specific, measurable, attainable, realistic, and timely, a SMART goal. Perhaps it is contacting one of the resources that might be more remote to re-engage a resource that, well, I had a friend from childhood, but we're not in very close touch. Well, maybe the goal will be to re-engage that resource. Maybe the goal will be to walk around the block for exercise, or do a little bit of stretching in the areas that the body feels sore and limited. Befriending the body. Maybe it's spending time with a little bit of mindfulness on a mindfulness app for a few minutes each day. And here I want to just say back to my physician colleagues, this is medical care. Don't feel bad that you're not ordering a test. That these strategies are absolutely therapeutic, and you're now creating a partnership between yourself and the patient, who may have been suffering with this disorder for years before they've come to you in this moment. And you've now started on a journey towards recovery. So don't be discouraged if it takes a long time. And your hopefulness around this will be a comfort to the patient as well, who is often quite discouraged by the time they get to you. So keep your own hopefulness and be realistic about a slow but steady progress. And so this is a message to the patient to be patient with herself, but be patient with yourself too, and that this is a shared journey, not a destination, and that you'll expect obstacles, because any additional stressors that may come along the way, any setbacks along that hierarchy will may worsen the symptoms, and that is all to be expected, and that your hopefulness and your reassurance and your determination will be a resource to your patient. So we wanted to also, because we're family-oriented providers, we wanted to also make note of the fact that the family can be a haven for healing. I wanted to tell you a little bit about a case of mine, a patient who, on the birth of her first and only child, developed paralysis in her dominant hand. was a very clear conversion disorder or psychophysiologic disorder. She was referred to me. As I learned and took care of her, I learned that her husband was an alcoholic and quite emotionally abusive towards her, and really exacerbating her under her pre-existing vulnerability due to some bullying that she was subjected to as a child. So really reinforced her sense of inadequacy. And so the paralysis in her hand was really a manifestation of her feelings of inadequacy as being a parent to this child that she so much wanted to care for and provide. And it turned out that her parents were really quite supportive of her. And by engaging her parents or her family of origin, it really helped to strengthen the patient. And she eventually came to see the abusiveness in her marriage, and eventually actually relied upon the support of her parents and was able to extricate herself from this relationship. So it just an example of how, and I never brought in the family, but that's something that could happen, where her family of origin became a resource to helping her recover. And of course, then there's the case of where the family is actually part of the problem. And another patient of mine who was the youngest of 6 children and had suffered quite a bit of neglect and prominent feelings of unworthiness and inadequacy, being the last one to come along in a very large family, was depressed and convinced that something was wrong with her. And this eventually manifested as body dysmorphic disorder, where she really thought there's something wrong with her skin. She actually has beautiful skin, not a thing wrong with her skin, but she's convinced that there's something wrong with her appearance. And eventually she learned that she deserves, her husband actually continues this emotional abuse. And so with time, she learned that she deserved to be happy. This is one of those patients that I use that exercise with, bringing to mind this young child and caring for her each day, every day, speaking to her, helping her to grow, helping to reassure her. And in time, she developed a voice of her own, and she's learned to become a better advocate of herself, and is learning to create some distance from her abusive husband just to protect herself in some more, with using more self-advocacy. And so she's doing quite well as well. But we certainly want to help her to end further victimization, avoid other perpetrators, create distance where that abuse continues, set limits, and control her expectations of what she can reasonably expect from these abusive members of her family. So that concludes.
Just jump in real quickly. I wanted to say that something I've come to understand since our last webinar a couple of years ago is that the outcomes from this approach are so good that they actually counteract a tendency toward burnout in primary care. I've seen this a number of times, and most recently in a physician who told me that these approaches have brought joy back into her practice, changing patients who are a source of frustration into a source of personal reward.
Thank you all so much. What a stimulating discussion. My head is kind of spinning in large part because what you have done is put into categories and words what so many of us deal with every day in primary care, and don't have those sort of categories to fit the work that we're doing with the patients in. So just that alone is tremendously helpful. And so thank you so much for that. I've got one of the participants here, Edward Dick, has a really good question that actually I thought of as well as I was listening to your presentation. You did a great job of addressing the connection between ACEs and psychophysiologic disorders. The participant was wondering, have you done any correlation or seen anything specific with ACEs and social determinants of health? For example, he says, have you ever looked at well-being assessments like the adult well-being assessment, 100 Million Healthier Lives, Cantrill's ladder, which I'm not familiar with. So those two parts there, any connections that you've seen in the literature with social determinants of health? And have you ever looked at well-being assessments like the adult well-being assessment?
The well-being, no, but definitely the social determinants relate to ACEs. The more ACEs you have, the more likely you are to be unemployed, lower socioeconomic status, and of course, intravenous drug abuse plays into that. History of selling your body for sex is higher with ACEs. Victimization by sexual assault, intimate partner violence is higher with more ACEs. So yeah, absolutely very strong correlations between ACEs and inverse correlation between ACEs and socioeconomic status.
So a sub-question that the participant had is also what models and tools you might suggest using to address food insecurity, housing instability, transportation, which are those SDOHs. So do you guys have tools that you use for those in particular, in addition to obviously screening for ACEs?
At our clinic, we have social workers or just bachelor's level staff that are very aware of resources in the area when it comes to employment, housing, healthcare organizations that will take Medicaid, for example. And usually the way, at least we do it at our organization, is like the healthcare provider or behavioral provider would refer the patient to this individual who connect them to the appropriate resources.
And
Awesome.
when people are enabled to feel like heroes, as Susan pointed out, I mean, they are much more energized about advocating for themselves. You know, they're much less passive victims. They're much more able to take control of their lives. So a lot of the, you know, a lot of people have had the idea that ACEs are something that happened in the past and that there's not much that you can do in the present, but nothing could be further from the truth. The outcomes that you can achieve both in mental health and in, you know, personal self-image and in physical symptoms are every bit as good as you get with organ diseases and structural abnormalities. So I think, you know, some of the fundamental self-image changes that we've advocated in today's webinar can really help empower people to put more of their own personal energy into turning their personal situations around.
Absolutely. And one of the other things that struck me in your presentation is, and you did a great job, by the way, of just being so practical. I feel like folks can take away some really practical tools to take home today. But what struck me was that the tools themselves are tools that are applicable to lots of different conditions, depression, anxiety, etc., not just psychophysiologic disorders, but that what you seem to be describing, and I want you to comment on this, is really that adapting those tools in a skillful manner for these conditions is the key. So for example, you describe journaling, but you really describe journaling in a structured fashion or in a tailored fashion for the individual patient and their particular condition, not just sort of a cookie cutter instruction, hey, you should start journaling. Same thing with like behavioral activation. It seems to me that to do this well, you'd need to have good MI skills as you encourage someone to begin behavioral activation or that self-care skill set that is missing in that individual's life to tailor it specifically. So if you could comment on just sort of the need to really tailor these interventions and be skillful, because on the surface it seems, boy, these are really pretty simple, straightforward interventions, and they are, but your thoughts on that?
I think once you have taken the history of a patient's ACE experience, then all of those interventions can be individually matched to what you know about the patient's personal experience growing up, and that makes it, you know, very directly connected to their own lives. An analogy that I make with most of my patients is for them to imagine their early experience as being like having been born on the far side of a dangerous mountain that they've then had to climb up and over to get to be an adult. And that emphasizes their lack of any culpability for the circumstances they found themselves in, but also emphasizes their courage and strength in having overcome those difficulties. And when they can think of their early experience in that way, it's a 180-degree flip in their self-image that starts happening. And all of the exercises that Susan reviewed in detail can then be directly connected to that process.
Well, I'm sure we could have an extended conversation on this, and we hope to actually extend this conversation to the conference where you all will be talking some more about this. Thank you so much for this work. We're going to be posting this on integratedcarenews.com on the video stream. And I'm hoping to actually also take a snippet of this conversation and put it up on our podcast for that audience to listen to and connect with as well. So thank you all for joining today. Thank you to our presenters today for an awesome discussion. Yeah, and as a take-home, I love your question, David, and that's going to be my clinical take-home for today. That is a great question to really get at it. Even if your clinic's not screening for ACEs in a formal fashion, any clinician can take that question home with them today and apply it and really connect meaningfully with patients with these medically unexplained symptoms. So that's my take-home for today. Thank you all for listening, and we will check back with you at our next CFHA event.
Thank you.
Thank you.